Any other thoughts, Ray?
Sorry, jump back in again. So I just want to pick up on
Just shout.
that idea of socioeconomic status as being sort of an undercutting between it. I think there's a mixture between socioeconomic status and education levels as to who can really benefit from genomic medicine. Because with the NHS and the healthcare system as we have it, it's very reactive. So if you are, don't have the education or you're particularly not wealthy, if something happens to you, we can act on it. What we're finding is that people who are in wealthier positions and higher education levels are able to think proactively and be able to access that and ask for those interventions before anything's actually gone wrong with them and ask those questions. So if we're going to bring genomic medicine into sort of the more mainstream, is there a case even for the NHS to look at it in that less reactive and more proactive method for everyone, but it needs to be in the healthcare system to do that rather than in these private entities?
Yeah, so we're thinking about, that's what I heard the Chief Medical Officer yesterday call personalised prevention. And personalised prevention, although I do think there's a lot of people who run away with the idea that if you were to find, and I'm now making this up as you'll all realise, an eating all the pies gene, then actually telling people that they've got an eating all the pies gene doesn't necessarily mean people will stop eating pies. And in fact, some of them may eat more pies because they think, well, why not?
Yeah, and I think it's a double-edged sword, and if you think about Alzheimer's disease and ApoE variants, it's that offers, if that was available on the NHS, I think it could allow patients to make a choice on whether they want to know, because if they do know, at least they have an opportunity to plan and about the future and make a will, do other things. So I think it does add value personally, but what are your thoughts?
But I don't know at what stage you'd offer that, because would you offer it in your 20s or 30s? Would you want that knowledge? Often I think people find that if there's something that they can do, they want to know. If there's nothing to be done, much like with the early years of HIV, where the idea, we treat it in a completely different way now, but in the 80s people did not want to know their HIV status, and all the testing was anonymous because there wasn't anything that they could do, and that knowledge was thought to be too burdensome to bear.
I think if you have a white man in a hospital telling you about your eating all the pies gene, I think people won't listen. But if you have someone that is who looks like you and is therefore more
like a pie,
is therefore more culturally aware, if they're more sensitive to the other person's lifestyle, then you can engage more, can't you? But just having a white man, someone that doesn't look like you, telling you, waving their finger at you, we don't respond in that way.
No.